and has a nice active stock portfolio. I misunderstood the instructions for disclosures, so I referenced some of mine. Don't get any of what I have, just like buy the S&P 500 or something like that. But they do not influence me for this talk. So this is Clinical Pathologic Conference. It's the 21st. I don't know why I put the 20th. I was obsessed with my mom's birthday or something. But it is the 21st of February today, in case your patients ask you whether you're alert and oriented. And today is the case of a 61-year-old woman with tobacco use, migraines, and anxiety who presents with a painful tongue lesion and pain while eating. A little bit on the history of CPC. I wish we had invented it, but we did not. So it originally started at Harvard, where they took the concept of case reports from the legal field and applied it to medicine, and then it spread from there around the country. It was brought to WashU by Dr. George Dock, and this is a picture of, quote unquote, the pit in 1953 of people enjoying this. And the Becker Library is our medical library here. So I'd like to introduce our expert, our first time discussant, Dr. Bryce Montane. Big round of applause. So he's going to be our wonderful discussant today. It is interactive. Expect to be called upon for help, not harm, for help. So we'll help Dr. Montane today, hopefully make it a nice interactive case. And we have a few slides about him.
He doesn't know that I put his face on this, so hopefully he sees it.
Awesome.
But yeah, that's me.
Well, thank you. Appreciate it. So we'll put up the one-liner again, as we like to say. So this is a 61-year-old woman who presents with a history of tobacco use, migraines, and anxiety, who presented twice, it seems, with a painful tongue lesion and pain while eating. So kind of as a first question I have for you, Dr. Montane, what are your initial considerations? Are there kind of pathologies that you're looking at especially, or organ groups?
So number one, when I first saw this, I was like, I really hope this doesn't, I'm not asked to interpret too many images as a red-green colorblind, and the tongue is usually red in my experience. So, but kind of breaking this down, I was kind of focused on the tongue lesion and the pain while eating as almost as like two separate problems. So the tongue lesion itself, you know, when we talk about, and I'm not going to focus just on the tongue, kind of just focusing on like the oral mucosa in general. This one is a little bit harder for me. And so I was really trying to go back to basics when I'm thinking about it. So going back to our original mnemonic for just differential diagnoses in general, which is Vindicate. So when we're thinking about like vascular disorders that can cause tongue lesions, you can think of something crazy like giant cell arteritis, granulomatosis polyangiitis. Thinking about like more infectious, inflammatory, that's probably where we see a good chunk of tongue lesions in general. So infectious, you can think of viral causes, CMV, HSV, EBV. You can think of bacterial causes, syphilis. You can think of fungal causes, histo, blasto, classically Candida is one of the big ones we always think about. Going into N for neoplastic or neurologic. Again, this would be more kind of the painful tongue lesion. You can think of things like trigeminal neuralgia. In terms of neoplastic, especially with somebody who is a tobacco user, you can think of pretty much any cancer that would ever go to the mouth. So you can think of anything like metastases from melanomas. You can think of leukoerythroplakias, squamous cells. Going into D for degenerative, I skipped this one. I couldn't think of anything degenerative that would particularly lead to a tongue lesion. C for congenital. Again, you can see some like really, really like interesting things in terms of congenital diseases. I'm gonna kind of skip it because I think we'll get a little bit too much in the weeds. A for allergy, autoimmune. You know, you can think of anything from allergies like just classic allergies, erythema multiforme, SJS. You can even think of some of like the bullous diseases like pemphigus vulgaris. Autoimmune stuff, this is also probably another hot place where we think of painful tongue lesions, which are like ulcers, lupus, Crohn's, quite a few different differentials you can come up with there. T for trauma, again, people just biting their tongue or just got hit the wrong way. I know I've put my own teeth through my lip doing a wakeboarding accident, true story. And E for endocrine, neoplastic. Again, these are a little bit more like endocrine, or I guess electrolytes would be the better way to phrase it. A lot of vitamin deficiencies, especially the B vitamins, vitamin C, iron deficiency can present with tongue lesions and cheilitis, a lot of ulcers and things like that. And then the pain while eating, that one I would probably, this one I'd probably need a little bit more information before I really delve in. But pain while eating to me is a little bit ambiguous. It could be something as easy as I have cavities and I have an infection of the pulp of the nerve of my tooth. This could be pain with chewing, like TMJ. This could be pain when I'm actually going to swallow, like odynophagia or dysphagia. Or it could even be pain like right after eating. You know, we see patients who have pancreatitis and they have a ton of pain right after. So that one, I'll leave a little bit up more for grabs.
Awesome. Thank you so much for that great differential way to frame a lot of the clinical problems that you all will face. So I'll dive into the HPI for this patient and then give some more information, then we'll pause again. So this patient described some tongue pain, pain and difficulty swallowing, primarily due to the pain as food touched the tongue that was worsening over the last 2 weeks. And she first noticed her tongue was tingling about 1 month prior, and she developed 2 tongue blisters about 2 weeks ago. She was given a series of therapies empirically to try to fix this: a Medrol dose pack, so steroid taper, nystatin, then fluconazole, and then valacyclovir, and none of these things seemed to improve her symptoms, so she presented. An ENT recently biopsied her tongue at an outside referring facility, and the pathology was pending at the time she presented to our hospital. And then she denies some of the things that you had mentioned: tongue biting, trauma, consumption of hot or caustic liquids or solids, and she doesn't have any ulcers or lesions elsewhere. Bill? Awesome. And then just a question, you know, when the team asked this patient if she had any ulcers or lesions elsewhere, you know, would that direct you any direction? Is there a reason that you would want to ask that, or narrowing your differential because she doesn't have those things?
So definitely if you're thinking of like lesions in other places, so, or just, you know, you can think of it more as like overall systemic diseases versus localized diseases. So in terms of like lesions in other places, so you can think of systemic disease like pemphigus vulgaris, where you'll get oral mucosal lesions, but classically you also get bullous lesions on the skin. You can think of Behçet's, which generally we think of oral lesions or ulcers kind of in the more groin area. You can definitely think of a more disseminated disease. So let's say, even though we usually think herpes is kind of like localized to the mouth, if someone has like uncontrolled HIV, seeing a disseminated version of HIV or CMV is definitely possible. I'm also very happy that you guys managed to get ENT to biopsy the tongue. I remember whenever I would call a consult for this inpatient back where I trained, not training here. If I called derm, they say call ENT. If I called ENT, they say call derm. And then if they both didn't want to see the person, then they say talk to a dentist. And as you guys know, dentists are pretty hard to come by in the hospital. But probably the thing that's standing out to me right now is the pain and difficulty swallowing. The nystatin should really be kind of focused on, you know, candidal infections, which is probably one of the most common things that we'll see. Valacyclovir really be targeting more herpes simplex virus. And a Medrol dose pack, everybody feels better with steroids. That's what I was always taught. So can definitely help with quite a few things. The pain and difficulty swallowing, the classic kind of differential for just odynophagia would usually be herpes, CMV, and Candida. You guys might remember from your step 1 days where they'll show you all the lesions, whether they're linear, whether they're rounds. And definitely other things like esophagitis in particular. So if it's more of like a primary esophageal problem, you can think of diverticula. You can think of eosinophilic esophagitis. I think right now I'd be interested in what the tongue lesion kind of looks like. and learning a little bit more about the pain and difficulty swallowing, whether it's more, at least I don't see it up here, liquids, solids, and kind of really basing my differential around that.
That makes a lot of sense. So you'll see a picture when we get to the exam. And just to mention, her pain and difficulty swallowing is primarily just with starting the swallow and eating. So even liquids, there was some pain, mostly related to the tongue, having a difficult time eating solids and liquids. They had mentioned in the chart that she was having trouble with secretions, but I think it was mostly because of the pain around the tongue and the fullness. Giving you some more history, she has the three items that we had mentioned before. There's no family history of head and neck cancers. She recently received some of these medications like the Valtrex and Medrol. She takes a little bit of medication for migraine. She has these allergies as listed for her social history. She works in a university kitchen. She does not have pets, no incarceration history, no recent travel. She does have about a 25 pack year smoking history, which comes out to about a half a pack per day. And then rare alcohol use, no other drugs. Diving into the review of systems, using our nice little color palette here, you can see that she has some intermittent chills. She has this oral phase of dynophagia related to the tongue, these purulent drainage from the tongue ulcers, and you'll see a photo soon. She does have some constipation that she is relating to her decreased intake, some subacute neck and back pain, and then some baseline anxiety, which we already knew.
One big question I'd have just looking at this, in terms of like, so tobacco smoke, poor oral hygiene, and just dehydration are definitely things that you can, basically risk factors for anything bad that goes on in the mouth. I know it says no dental pain here. Does she have any obvious caries, gingivitis, or swelling or discoloration of the mouth?
So she had seen a dentist before this, and I think she had seen them for caries, but there hadn't been much pain related to that specifically. And the dentist had seen this, and then I think was the initial person to try some of the nystatin and some of those treatments, but no other significant gingival disease that they could see. It was just related to the tongue.
Okay, good. And
Right.
the thing that's standing out to me now is when you think of kind of just dysphagia in general, whether it's more of an oral dysphagia or kind of more esophageal dysphagia. Again, I didn't do that. Typically thinking like if food is actually more getting stuck or if it's more the initiation process of it. And it can be a little bit difficult because you could think of something primary in the mouth, whether it's an exposed nerve, tooth problem, ulcer that you're not quite seeing, an abscess, or even whether it's like referred pain from like some of the ears, the sinuses, and things like that. So that's kind of what's going through my head right now.
Yeah. All right, so we already went through some of those thoughts. So looking at the physical exam, everyone should just pretty much look at the picture. And while you're looking at the picture, I'll tell you her vital signs were stable. The tongue lesions are as shown. They were erosive. They did not have bleeding. And the rest of her exam was normal, noting that there weren't any other rashes or ulcers or lesions elsewhere that they could find. Heart was a regular rate and rhythm, no additional sounds there. She was not febrile.
Going through and kind of just looking at this tongue lesion, thankfully, I can see it. I definitely see some abnormality. Always worried about the red-green. So some of the things that I'm thinking about directly looking at the tongue. So I'm seeing some kind of greenish brown, kind of there on the right portion of like towards the tip. I'm seeing some kind of darker. Is it okay if I just use the mouse?
Yeah.
Probably just here.
You can use a laser.
So seeing some definitely very scary looking stuff here. Seeing a particular shine of this tongue and seeing kind of this like, white filmy part. So just looking at the lesion itself, some things that I'm already kind of ruling out of my head. So erythroplakia is like one of the common things. Typically it's kind of a red lesion due to erythematous growth of the tongue. What it usually has, it's usually very susceptible to bleeding. Your leukoplakia, which would be kind of more like something like this, where it's kind of a white film and typically is not something that's going to come off with scraping. This here definitely looks more necrotic. And so now I'm starting to think basically more my autoimmune conditions as well as my cancers, especially in a tobacco user. So this biopsy is going to be looking very, very juicy soon, and I'm very interested to see what I'll have. The other things I would think about just kind of looking at someone's tongue, you can see fissures, which is like kind of a pretty common benign finding. Sometimes the other things you're looking for are patches of like atrophy or atrophy. So those can be associated with things like syphilis, things associated with like lichen planus. But again, we didn't really have any other systemic symptoms to kind of support those differentials. Um, and it looks like, relatively speaking, everything is kind of really localized to the tongue. I'm not really seeing any other symptoms, pains, ulcers anywhere else. So right now, my biggest differentials are probably centered around infectious causes, neoplastic causes, and other inflammatory.
That makes a lot of sense. So we'll give you some initial labs. So just pointing out here, the chemistries were all essentially within normal. There was a CBC with some leukocytosis, and her initial hemoglobin was normal. All right, with some absolute neutrophilia, some lymphocytosis, monocytosis, or EOs was 0. So we're moving on to the initial diagnostics that you want first. So I'll bring up our nice little slide here where we can dive into a lot of different options.
So definitely something right off the bat I would think about is a lot of these things will be kind of much easier to tell under histology, but just thinking out loud. So especially infectious causes, tongue lesions, one of the first things I don't want to forget to say is HIV. Kind of talking about this case. Ordering like localized, like, or I guess blood of like HSV, CMV, EBV, PCR, and things like that. Sometimes I find them to be helpful. Sometimes when they come back super positive, I end up calling ID and saying, hey, I found this. And they're like, yeah, you probably have that too.
Yeah, that makes sense.
For rheumatologic disorders, the biggest thing I would think about with somebody looking at the case that we have so far, I would probably start to think a little bit about lesions that would predispose to infection, so even like Sjogren's labs. And typically, some of the other differentials I was thinking of, more like lichen planus or more like a pemphigus vulgaris. Most of those kind of things you're going to see on biopsy. This would kind of come along with like, if it truly is necrotic, honestly, I think just doing an overall head CT just to see if there's any involvement of the sinuses or anywhere else apart from the tongue would be a pretty good start. And I would definitely do it with contrast so that way I can look for signs of abscesses or other infections. In addition, I may be able to see any involvement of the blood vessels themselves. So let's say this was like a truly, truly bad fungal infection. You can definitely see things like mycotic aneurysms kind of associated with it. In terms of urine studies, and blood studies, I think we can also additionally add like histo, blasto, and we can definitely look we can even just take like a simple scraping, just look for hyphae and things like that. For Candida, I'm staring at the fact that there's a cardiology button here, and I'm wondering if I'm forgetting something from a cardiac perspective. But
there is a cardiology button. There is. What is behind the veil is not.
And through my head right now, I'm like, heart, tongue, heart, tongue.
Chocolate. So let's go through a little bit of this so far. So we'll give you kind of the early infectious evaluation that was done in the emergency department. We'll be again kind of with that. You've already given us a lot of suggestions as to what infectious etiologies might present this way. This patient, they're in the ED, so they get, this rapid testing done. Interestingly, the HIV rapid testing was positive. And there's an infectious disease consult along the way that I can reveal iteratively. And then they did an RPR in the ED that was negative. They did send HSV in the ED that was negative. All right. So you talked a little bit about the heme workup that might not be as helpful here, cardiology workup. I want to reassure you that in this case, the cardiology workup, I don't even think they got an EKG when this person came in the ED. They did get an NM SPECT 2 years later. So we won't go into that for you right now. So for the heme workup, I'll just point out, because you had mentioned, vitamin B12, things like that. During her hospital stay, she maintained her leukocytosis, but became somewhat anemic. And then they did get these studies here. Her B12 was normal. Would you expect anything in a patient who doesn't have bleeding during the hospital stay, kind of the revelation of an anemia? Does that change anything for you?
So generally, like a hemoglobin like this, it's not super profound whatsoever. It does make me feel a little bit better that the peripheral smear is normal. Again, especially with like EBV virus, mono, is kind of like our oral pharyngeal viruses. Even something as crazy as like acute myeloblastic leukemia, where you can get gingival findings. That does make me feel a little bit better. The fact that I have kind of my own way of kind of looking at iron deficiency labs. In general, for me, usually I just start with the ferritin. If the ferritin is, let's say, below 30, then it's pretty classic iron deficiency anemia. And again, we were thinking about like iron deficiency associated syndromes, even like a Plummer-Vinson, that can cause oral pharyngeal dysphagia and things like that. The fact that the ferritin is normal here, or at least elevated, again, is a sign that we likely have some kind of anemia of chronic disease. But even in the setting of someone with anemia of chronic disease, if their ferritin's above 100, then it's more than likely that they don't have a true iron deficiency. The only time I will say there's a little bit of a caveat with this is in somebody with really profound CKD. The nephrologists that I've worked with in the past and some of the New England journals have shown that when you shoot for ferritins of 300, 500, that you're still seeing benefit from the repleting iron. I had one of my nephrologists from back home shoot for ferritins of 700. But I'd say from this, B12 looks normal. I saw the folate had a dash, so I'm going to assume it's okay. And looks like iron is doing perfectly well too.
That makes sense. So moving a little bit, I'll just say that we'll go into imaging just briefly. I'll say that when the patient came in, I'll do a little introduction for Dr. James Burke, who's our neuroradiology fellow here. So the first imaging that was done was not done at the Mallinckrodt Institute of Radiology, which I would like to argue is one of the best, if not the best, we'll definitely say one of the best and be kind to our colleagues. Radiology departments in the country, where as applicants, just want you to know that it's an expectation that all reads are done by 5 p.m. same day. So not just 24 hours, but you get same day fast reads done by experts. So the first CT that this patient had, a CT of the neck with contrast, no acute abnormality of the neck. And that is what the patient presented with. And you mentioned that there is other imaging that might be helpful. Is there any other imaging protocol that you might want for this patient?
So thinking out loud, CT soft tissue of the neck. Typically the things I would be looking for are, especially when we're talking about lesions that look like cancer, one etiology I should have mentioned earlier would be like HPV. So looking for other signs of like HPV associated cancers, like laryngeal cancers, looking for associated thyroid cancers. The fact that those aren't there doesn't make me think there's at least kind of like a local spread of infection. In addition, does somebody who, we kind of already declared that this is more like an oral pharyngeal dysphagia, but the things I'd also be concerned about are like peritonsillar or retropharyngeal abscesses, but it doesn't look like we have really any involvement here. So it looks like, again, we have kind of honed in, and I would still be interested to see what's going on right about here. So basically seeing if there's any involvement of the sinuses, any involvement of like the salivary glands, the parotid gland, the dentition, anything like that.
Mhm.
But does make me feel a little bit better that some of our soft tissue neck stuff is kind of ruled out with thyroid. Again, HPV is still possible, but a little bit less concerned now that there's no laryngeal obvious signs.
That makes sense. So we're kind of thinking maybe vasculature, infectious,
Mhm.
still thinking maybe a little bit malignant. So you mentioned some other imaging that might be helpful, and we have an MRA of the head and carotid with and without contrast, and then there's some additional imaging that comes a little bit later on. So we'll just point out, we have some anatomy of the neck that Dr. Burke provided for us. You kind of remember these images here. And so we'll bring up, if you don't mind grabbing the mic for us, we'll bring up kind of what some of the normal arteries of the neck look like here. Do you mind commenting even briefly on what we see in this image here, where the arrows are?
Real quick, just because you mentioned it. So you mentioned kind of some varying areas. So a CT soft tissue neck normally has a field of view that extends from about the forehead to the base of the heart. So for all those things like sinus dentition, you will see it, and parotid glands, they'll all be included.
Okay.
So a normal read would effectively be excluding them unless they just didn't talk about it.
I appreciate the clarification. I'll
For you
definitely keep
guys
that in
too.
mind for the future.
And in this case, so the arrows are, like the previous slide showed, the external carotid artery is the kind of redheaded stepchild of neck vasculature that we never look at or think about, but it's still there. And in this case, these are the paired lingual arteries that are supplying the tongue, which are the third branch of the external carotid artery. And then this is an MRA, just again, talking about small vessels. MR and MR angiography is worse in many capacities to CTA because it lacks spatial resolution. You can bump it up by imaging with a higher Tesla scanner, but that can increase the time, and it can be very uncomfortable for patients. So just showing that they're not really great at it.
And so we have the initial imaging that this patient had in 2022. So pointing out there was both an MRA of the head and neck and CTHS that was simultaneously done, but we won't have the images here. And they demonstrated these tortuous vessels near the angle of the mandible. And then we had already, Dr. Burke already made the comment about spatial resolution. But any kind of overread that you might have here?
With the diagnosis is at the end, so I don't want to give it away. But
Right.
No one commented on the vessels that I pointed out originally, which is very fair game because, like I said, they're honest. A lot of times we don't talk about the external carotid vessels because they seldom matter because we care about strokes and interventional stuff, and no one's going to go after them. But there are tortuous vessels at the mandible.
As a question, like how, and again, I'm asking this more as the audience member. So when you have somebody who had if say they had a granulomatosis with polyangiitis or a giant cell arteritis, how well are you able, in terms of branches off the external carotid, going back from my memory, you're typically thinking maxillary artery, you're thinking inferior alveolar artery. How well are you able to kind of see and differentiate?
Depends on the modality.
Okay.
So kind of if you're just looking at how do I see the vessels, the gold standard, or really the gold standard for any vessel, is a conventional angiogram, which we seldom do. CTA is functionally the same as far as best spatial resolution, and then MRA, if it's a large enough vessel, you can see it, but kind of with the pictures, these very smaller branches, particularly the early ones like the ascending laryngeal and the superior thyroidal, you will not see them just because they're so small.
So the CAT scan would probably be the best bet then, apart from maybe an angiogram, you said?
Yeah, the CTA is always a good first look when you're just trying to say, what are the vessels doing?
So they didn't have a CTA at the time. They did have one 2 years later that we can show you in a little bit. But I'm just going to dive back just briefly to show you some of the other labs that you had mentioned before we go further in radiology or pathology. So we have some additional infectious evaluation that you'd mentioned here, coming up negative for some of these infections that you had mentioned. Negative RPR, the HSV was negative, VZV was negative. A T-spot was done. HIV was positive, but then the antibody assay was negative and there was no viral load. So that kind of ruling out some of the infectious etiologies that you'd mentioned. You had also mentioned some rheumatologic serologies, so pointing out that she did present with an ESR of 32 and a CRP of 13.6. You had mentioned a number of other etiologies. So rheumatoid arthritis, that workup, negative there. The ENA panel, which can cover a number of different autoimmune processes, was negative here, like can be positive in Sjogren's, connective tissue disease, scleroderma. dsDNA looking a little bit more at lupus was negative. CK was normal, which can be helpful in kind of myositis-related diseases. And then the rheumatology team that joined on later did an ANCA screen that was negative, and then the ANA was negative. And then I kind of a question I would ask you for as you move through this patient's story, would you repeat an ESR and a CRP during this admission? Or would you, you know, are you going back and collecting more history if you don't feel like you have an answer yet?
So definitely always game to collect more history, but repeating the ESR and CRP, again, generalized inflammatory markers, you know, it's interesting when they're positive, but I don't necessarily know what to do with it sometimes. You know, let's say if your ESR is above 100, typically you're starting to think of things that can really cause that sedimentation much quicker. So you're thinking of like very bad malignancies, you're thinking of like sepsis infections, you're thinking of even with like multiple myeloma, that Rolo formation that you guys might remember where they kind of stack on top of each other. CRP, again, kind of more as a generalized inflammatory marker as well. Sometimes like in lupus, you know, sometimes you'll see like an elevated ESR, but a normal CRP, and that's because certain lupus etiologies can actually downregulate CRP. I'm going to assume that in the ENA panel, we have like the Sjogren's labs, because those are kind of the particular ones I was thinking about. Overall, the only other thing I'd say about this ESR and CRP is the ESR is probably borderline high when I correct for age and gender. The CRP will definitely be high once I correct for age and gender. Those inflammatory markers, though, are based on like, those corrections are based on people who have rheumatoid arthritis. So you have to take them with somewhat of a grain of salt. But I'd say the ESR is only probably borderline high and the CRP is definitely high.
Gotcha. That's helpful. They did repeat them, and just to point out, they were higher throughout the hospital stay. So diving back in, so we've gone through a little bit of our vascular imaging. We noticed that there's some tortuous vessels right around the mandible, kind of in the area where there's a necrotic lingual tissue. Much of our room serologies are coming back negative, as is our infectious panel. So we have ID was consulted, rheumatology was consulted. You know, they were pointing fingers or asking each other to comment throughout. And they were getting more history, learning that, you know, she has a history of migraines, but she did also have some substantial headaches that seem to have come on a little bit more in the last month. She, you know, had pain with her tongue, but she also had some pain while she was chewing. So we have some pathology here. So we'll point out, we have Dr. Axelrod here, who's with us from the clinical pathology department in the physician scientist training program. So we have a biopsy on 6/2 of the tongue that was done. She was excited to have her tongue biopsied a second time. And then there may have been another biopsy, but we'll begin with the biopsy of the tongue.
Are we going to see giant cell arteritis?
Well, we're going to start with the tongue. So can I use the pointer?
Yeah, please do. Yeah, we'll get the laser.
Great. So here's a nice punch biopsy of the tongue. They did a really nice job of biopsying the side of the ulcer, which is what we like to see. So we can see the squamous epithelium here, kind of behaving itself just a little rubbed up and sort of devolving into ulcer here. And then you see a big inflammatory infiltrate here. And you can look in the submucosa, you see lots of vessels and lots of inflammatory infiltrate. Thanks. Higher power, you can see some neutrophils in the epithelium. I'm not seeing any evidence of fungus in the epithelium. And you can see a lot of neutrophils down here as well. This looks like some granulation tissue with lots of vessels. Notably here, I'm not seeing any evidence of vasculitis. These are just sort of normal reactive looking vessels. I'm not seeing any viral cytopathic effect. I'm not seeing any granulomatous change. This is kind of a standard ulcer biopsy for us. Looks just like an ulcer without any specific things to point a finger at what it was called. And so telling you just a little bit the results of some additional stains. Immunofluorescence was done and we didn't see any antibody deposition. I also didn't see any blistering in the epithelium there. We also did CMV stains that were negative. A GMS stain didn't show any fungus that I couldn't see on H&E, and a Congo red stain didn't show any evidence of amyloid.
So we have this tongue biopsy done, and we've gained a little bit more history. We have the labs here. Are there any etiologies that you'd want to start treating empirically immediately and then lead your further testing at the conclusion of the hospital stay?
Kind of just going based on the whole story, because everything is, it sounds like what a lot of what they're seeing is just inflammation and just damage of the overall tongue without really any like cancerous findings, without any infectious findings, without any classic vasculitic findings. Mostly the way I'm kind of reading this is you're mostly just seeing inflammation or necrosis of kind of all the places that we've looked at. So thinking back to like conditions that are more urgent that we could treat empirically, because we had to do this when I was on service last week. Like a giant cell arteritis, typically the way to do something like that would be to have a temporal artery biopsy, but generally starting like high dose prednisone to begin with. In terms of like treating infectious etiologies empirically, our HIV came back negative, our RPR came back negative, our HSV, CMV, all those things came back negative. Blood pressure was normal, no signs of infection, definitely some pain on the tongue, but I definitely don't have any trigger right now to empirically start any antibiotics or even like any antifungals, because I don't really have any evidence of that. And ultimately, if we have another biopsy that shows cancer, you know, there are some times where you treat cancers of unknown primary, like if it's a squamous cell carcinoma, you can consider starting like platinum-based therapies, even if you don't know where the original lesion is. But right now, I don't really have any evidence that this is cancer. So the only thing that would push me to do earlier treatment is, based on the scenario, would be more like treating for a vasculitic disease like GCA.
Awesome. So they started with some additional history in their level of concern. They started some high-dose steroids, and they got in touch with the vascular surgery team to get a temporal artery biopsy.
So you can see our temporal artery here, nice big medium-sized vessel. Look, can I make this go back to the pointer thing? Pointer.
Yeah.
Laser pointer. Great. So you can see our vessel here. And already at low power, you can see this is not a totally normal vessel. All this blue stuff here is inflammation that shouldn't be here, in both the adventitia and spanning through the media into the intima as well. And you can see the better power of the inflammation here. There's some eosinophils in the intima of the artery. There's some lymphocytes. You can also see some epithelioid macrophages, and they're destroying parts of this artery. Notably, I also can't point out the internal elastic lamina because it's destroyed by these inflammatory infiltrate. And here's a nice higher power view of a different part of the artery. You can see more of these epithelioid macrophages. You can see a nice happy looking cell there. You can see this is a giant cell, part of the inflammatory infiltrate in this artery. And I guess I'll pause before giving you our final read.
What was the first thing you said in your differential at the beginning of the talk today?
Don't remember.
Okay. Maybe go with it. Yeah. What do you think?
But I did hear the word giant cell. So definitely kind of like this overall picture, we have somebody who has kind of these necrotic lesions, has some inflammatory cells, no signs of infection basically whatsoever, no signs of cancerous cells whatsoever. So vasculitis like giant cell arteritis.
And this was signed out as consistent with giant cell arteritis. With our new guidelines, we would sign this out as something like active arteritis involving giant cells. Giant cells are neither sensitive nor specific for giant cell arteritis, at least histopathologically, but this is a very classic picture that's overall consistent with that, and it sounds like it's consistent with your clinical picture as well. But just to note that the path is not necessarily specific for the diagnosis, even though the giant cells are often quite helpful.
Awesome. Thank you so much. Let's get a round of applause for, thank you. Right. And to just point out a few more things, the patient followed up in rheumatology clinic, was started on tocilizumab, which is an IL-6 receptor blocker. She has had some recurrence of ulcers with that, so has had to go through several different series of steroids. She's been most recently, last month, started on sildenafil to help try and improve blood flow. To Dr. Burke's point, just wanting to point out that vasculitis imaging is multimodal. CT has high resolution, a faster workhorse. Ultrasound is cheap and non-invasive. And then MRA, some difficulty with spatial resolution. Want to encourage all of you to type into Google the next time you want to order imaging, to type in ACR appropriateness criteria. And then kind of the middle of the first webpage you have are kind of guidebooks on the American College of Radiology's appropriateness criteria based on kind of symptom and organ system. They'll then give you a list, a table of all of the different imaging studies, and they'll have green for these are the most helpful, most useful, and then kind of midway through some yellow, maybe you don't use this, and red, definitely don't use this imaging protocol. Can be very helpful. Just wanted to throw that out as Dr. Burke was recommending. And then giant cell on arteritis on imaging. There's a classic halo sign on ultrasound. And then WashU has a vessel wall protocol for the brain at the moment, but may miss, as you were pointing out, some of these external arteries, and then CTA can be helpful. And then I just wanted to point out a few things here. So this is the patient's age was kind of characteristic, however, not characteristic in terms of presenting symptoms, hence the CPC case. Sorry about that, Bryce. Presentation with tongue necrosis is in like less than 6% of patients. But when you gave us your Vindicate, the very first thing you said was vasculitis, like GCA, temporal arteritis. So it was the first thing he said, which is always nerve-wracking for the presenter. But to point out, they went back and got more history, encouraging all of you to get more history on your patients. The history you got in the ED should not be the only history that you take, because she had better memory of, yeah, I had, some soreness in my jaw while I was chewing, kind of, so the jaw claudication, did have some worsening headaches. You heard migraine, so is this a new headache? Trying to differentiate that. Biopsy is gold standard, but it does depend on how much of the temporal artery you take, because you can miss the lesions. And then ultrasound reads are fairly skill dependent. So there's a large predominance of temporal arteritis, giant cell arteritis in kind of Northern European populations. And so Europe is actually quite good at reading ultrasounds. I've heard in, some places that I've worked or talked to that, some of the skills, and especially further out that you go from a major academic center, there may be less expertise in reading an ultrasound of the temporal artery. So if it's negative on a temporal artery ultrasound, wouldn't necessarily say that it's negative overall. And then tocilizumab is approved for its treatment. But thank you so much. And thanks again to Dr. Burke, Dr. Axelrod, and Dr. Montane. Nailed it.
It didn't feel like
Thank you so much. Great.